It gives me great pleasure to introduce our next speaker. I have been a long-term admirer of her advocacy work for at least 10 years now. As a long-term survivor of ovarian cancer, she works extremely hard to change the survival rates. We are extremely grateful that her efforts are focused on improving life for women through cancer research. Please make welcome the chair of ANZGOG's Consumer Research Panel, Wanda Lawson.
Do I need to click it on? Just that one?
I think so.
Let's try. This is not the correct presentation. Okay, slight hitch. Good job I have my notes. We might have to go without a presentation because I can see that they've actually loaded the wrong presentation.
I'll find it.
Look, I'll just start talking anyway. As Karen said, my name's Wanda Lawson. I was diagnosed with ovarian cancer in 2004, and I'd just like to add my own personal, I guess, endorsement of what Di said earlier, because contrary to, sorry, the lady over there who said she was advised not to exercise through her treatment, I was very determined to exercise through my treatment, and I had a great surgeon who supported that. And I undertook quite a rigorous exercise program very early in my chemotherapy, and I did resistance training, hydrotherapy. I was lucky enough to participate in a trial exercise program in hydrotherapy for women diagnosed with gynecological cancers, and also did some light jogging towards the end of my chemotherapy. And I'm very proud to say that a year after completing chemotherapy, I actually went ice climbing in Alaska, which I think attributes to my core strength. I would have to say I'll never do it again because it was absolutely terrifying, but anyway, it was really quite good. So I'm just going to try and wing it a little bit without my presentation while they're getting it sorted out. Is it coming, or shall I just keep going? It's called the Consumer Research Panel. I'll read out what's on the slide so we don't miss anything. So ANZGOG is likely to have engagement this year with around 300 consumers, and that's on an annual basis. We speak to a lot of people. I'm the chair of the Consumer Research Panel. I've been involved with ANZGOG about 9 years now, and it was through Karen Livingstone that I was originally introduced to ANZGOG. My passion for, I've been an advocate for women. I don't know if anyone else is from the UK, but you might remember this little symbol here, because about more years ago than I want to remember, I was one of the women who wore earrings like this when we all protested at Greenham Common against the American missile bases way back in the 80s, I think it was. So I really love the fact that they have this on the ANZGOG brand. It's a real strong symbol for women. And I have been a passionate advocate for women ever since my university days. And when Karen asked me to get involved, I thought, yeah, that's absolutely right up my street. You know, I've been affected by a gynecological cancer. I can now advocate for changes in outcomes for women. And one of the reasons I have done that is because I do believe and I understand that all improvements in the outcomes of women who've been diagnosed with a gynecological cancer have been made on the back of clinical trials. It is the way forward for us. And talking to consumers, what I believe consumers want the members of the Consumer Research Panel to do is to advocate for women affected with gynecological cancers want ANZGOG to innovate, drive support for and conduct research trials to improve outcomes for women affected by gynecological cancers. At every meeting that I have with the Consumer Research Panel team, we say that statement. I know it's a little bit old-fashioned now to talk about a mission statement, but I'm from the world of business. And again, about 15 years ago, they were all the rage, and I think it's really good to remind us why we do this. ANZGOG's Consumer Research Panel, I'm sorry I'm having to read, but I've got my notes anyway, which is just as well, but anyway, I'll keep going with it. The ANZGOG Consumer Research Panel is the mechanism for advice and input for gynecological cancer survivors and the carers to the Research Advisory Committee, the tumour working groups, the board of directors and our members. So we have a direct line in as consumers. The Consumer Research Panel, or CRP as I'll shorten it to now, helps ANZGOG to effectively represent the needs and expectations of gynecological cancer consumers, and it helps set general research directions and priorities and shape and research for ANZGOG. We are, as part of ANZGOG, we are really lucky enough to be at the forefront of participation in research. We just don't look at a form that's issued to a patient, a consent form, although we do look at that. We are right there in the development of the concepts. I've had two really gold moments at the ASM today, and one of those was when two researchers came up to me and said, you know, Wanda, based on the feedback of your consumer research panel, we're adapting our trial. We were worried about this little bit of the trial, and you guys picked up on it as well, so we're going to make a change to that. And you know, that's a pure moment of gold for consumers. The second one was in our Research Advisory Committee this morning, when I've been involved in that committee for 5 or 6 years. And when we first started in this, they would say, oh yeah, the consumers can stay for all of the concepts. Today, they said to me, Wanda, you have to leave the room. You are so involved in the development of this concept. When we discuss it, you will have a conflict of interest. And I think it was John, who's sitting over there somewhere, saw me leaping up and down with excitement. He said, Wanda, you look like you're floating on air when you worked out of there. And I was, because that is, it shows that here at ANZGOG, we work in partnership with our researchers, and we really do have the opportunity to influence where research is going for women and the outcomes for women. Why do we think we have the skills to do that? Well, on my team, I have people who support ovarian and endometrial cancer, lymphedema, Lynch syndrome. We have a carer. They come from New South Wales, Queensland, New Zealand, Tasmania, South Australia, and they cover city and regional areas. We have a couple of vacancies. Cervical cancer is not covered yet in some of the states, but we are still in a continuous process of recruitment. As well as the skills and experience, their lived experience with a gynecological cancer diagnosis, we have a business analyst, a mental health nurse manager, a health educator, a communications manager, a consultant in health literacy, a registered nurse, and a trial coordinator. So we do bring a really good skill set, and we utilise that skill set. And when I took over this panel a year ago, with Alison Evans, who's our CEO, we started to rigorously interview women, because participating and advocating for research is not for everyone. It's quite different from being involved in a support group. No less valid, but just different. So, it is important that you bring you bring the position of being able to be an informed consumer to that. Some of the activities that we undertake, I'm sorry, this slide is a little bit, can you still hear me because it's a little bit, so we participate in, not only do we participate in reviewing the concepts and the information that comes out of the RAC, we're involved in working parties discussing the development of research. So, for example, the team, at this ASM, we're involved in the development of designing a dilator that's used by women in cervical cancer treatment after they've had radiation. I don't know if anyone's ever seen one, but it's a pretty ordinary piece of kit. So we're working with the team in an attempt to actually try and design a better dilator for the future. I personally have been involved in doing some what I call user testing. So there was the development of an online support service to manage fear of recurrence, and we tested that as part of our team. And as I mentioned, we're associate investigators on many concepts. So when we are doing what I call our core business, which happens about 4 times a year and prior to each of the Research Advisory Committee meetings, where our researchers submit their concepts, we review those concepts from the perspective of a consumer. So I'm not medically trained. I have no idea about the correct dose of chemotherapy to be delivered. That's looked after by many people. The concepts are reviewed by clinicians, statisticians, oncologists, radiation oncologists, all sorts of people, and consumers are only one part of that, and we look at the consumer aspect. So primarily what we look at is the safe process of a woman through the trial. We look at what's being asked of these women. Is it is it onerous? What is the financial burden to these women? Just to give you a little example of something that we picked up recently, in a trial that came out, the description was that a woman would go into hospital 1 week to have a blood test, and the following week they would go in to receive their treatment. We asked the question, do they need to be separate? Do they have to go? Can they have the blood test at the same time as they go in for the treatment? In this case, they could. How much time has that saved us as women out of our day or out of our week? So we really look at the little things like, little things. I don't think they're little things, actually. I think for many of us, they're big things. To enable our team to continue to participate in research, it's important that we stay across current trends. And this year we had 2 training sessions for the members of the team. One looking at the quality of life aspect. And again, as consumers, we very much look at, survival outcomes versus quality of life. So we got some training from the Quality of Life Office in what questions we should be looking at and making sure we're covering all the bases. We also got a presentation on health economics. For a lot of people, the cost of participating in a clinical trial is covered to the extent that you have the drug, but many other things are not covered. So, for example, the side effects that come out of the drug, you may have to take some anti-nausea medicine. That may not be covered. So we wanted to get a presentation on health economics, and ANZGOG is very proactive in providing us with ongoing training. Last year I was also lucky enough to represent ANZGOG over in the US. There's a group called CCGC, which is a international trials collaboration group, and for the first time ever they invited a patient advocate to one of their sessions, and it was an absolutely fantastic experience. I went on ANZGOG's behalf, and part of my role there was to go along to a meeting with the pharmaceutical groups and talk to them about the importance of data sharing within a safe space, so within a safe database, because obviously the pharmaceutical companies, some of them are developing drugs that do the same thing, so there's a little bit of friendly rivalry that goes on, let's say. And it's very important for us in a country where our population is quite low that we have statistical numbers to support getting a drug on the PBS. We were talking about an immunotherapy drug earlier. So we went and talked to these people about a willingness to share their information in a safe space which elevates the numbers of people to responding to a trial, and we can utilise that. On the back of that, I went across to an amazing cancer conference out there called ASCO, and there was 30,000 people at that conference, and it's the forefront of the cancer conferences in the world, and it was just a wonderful learning experience for me to meet and network, and to be able to talk to other people about what we do, and to understand what they do internationally. And one of the things I took away from that was the fact that they had this great patient space at the conference. So many of the people on the panel are going through, on the consumer research panel, are going through active treatment. You can imagine coming to a conference where we get to go to sessions that are presented by clinicians, and sometimes we see quite graphic pictures of surgery. Some of our people need a time-out space. So I brought that idea back from the US, and it was implemented by ANZGOG here, where we had our own room with sofas. So if there were any sessions that people needed to take a break from, they could come out and take a rest. I know we're running a little bit behind time, and I just wanted to briefly finish on a positive note and say some of the things that we are considering for next year going forward in our consumer research panel. I need some more members from some of our allying states. I need cervical cancer to be covered. We don't have a representative at the moment. Our recent representative retired from the committee after many years of committed service. We want to look at health literacy of consent forms, and particularly inpatient information consent forms. Don't know if anyone's ever read one, but sometimes they are quite complex. We want to advocate for simple language and for translation of that consent form without falling into 4 basic language that are important here in Australia. We want to talk to our Indigenous populations in our remote areas. And I'm really sorry, I can't quite read the rest of my slide, it's a little bit down there. Ageing population, that was the last thing that we really want to focus on, the ageing population and the youth population. We're all, at the moment on the panel, we're all kind of middle-aged women, so we're looking for more representatives. Thank you very much for listening to me today. They loaded my presentation from yesterday, but that's okay.
Which I believe was fantastic, and we probably should have played it, but anyway. I apologise to Wanda profusely for not being able to share those visuals with you, but you will agree with me that was a pretty amazing brief of work, and we're very proud of the work that the Consumer Research Panel does, and they are a very respected and very important part of the ANZGOG process. Bear with me. Right, our next speaker. Our next speaker is Viet Doyle, Dr. Viet Doyle. He is a radiation oncologist, the Director of Services at Liverpool Cancer Therapy Centre, a senior clinical lecturer at the UNSW. I probably said that wrong. He is skilled at brachytherapy and image-guided radiotherapy in the management of gynae cancers. Dr. Doyle is an ANZGOG member, and he is here to present our session, What is the role of radiotherapy in a clinical trial, both in isolation and with chemo? Please welcome him to the stage.
Thank you very much, Karen, for your kind introduction. Let me just start by saying how humble I am to see how Wanda react to the absence of her slide. You only see that in patients. Had it been a doctors, we would have thrown the town and gone home. You know, I always in awe at the strength with which you as our patient and carer, that mental and physical strength going through the treatment, then have that strength to expose the vulnerability, to share your experience, and coming to organization like ANZGOG to help us. I thank you for that. We are different clinicians, different physicians of different craft group. We are scientists, but we speak with one voice at ANZGOG. And that voice is how we could have the best available research that available for women in Australia, in New Zealand that are affected by cancer. And on that note, I would like to share with you a little bit about radiation therapy and the clinical trial in ANZGOG. So what I would like to go through today is, what is radiation therapy? Is it an effective, is it an inexpensive treatment that we should consider? Should radiation therapy be considered in a setting of clinical trial? What have we done at ANZGOG? Where we would like to go in the future. And this definition are taken now from radiation oncology targeting cancer, which is a body group from our college to try to engage with our GP, primary care physician, with our patient to say that this is in Australia, we are very lucky to have freely available radiation therapy in all public hospitals, most public hospitals. So radiation therapy, or radiotherapy, or RT, as we call it, we use radiation such as high energy X-ray, gamma rays, electron beams to kill or damage cancer cells and stop them from growing and multiplying. Radiation therapy is safe and it is effective. It involves the controlled application of radiation to cancer anywhere in the body. And there is technological advantage that allows to scope the dose where we don't want to give. And also, we also know that the cancerous cells are almost always more susceptible to radiation than healthy and non-cancerous cells. And therefore, if you give radiation over a number of days, with 24 hours in between, your normal healthy cell can have time to recover. Let me spend a minute or two to try to convince you that radiation therapy is a very cost-effective cancer treatment. Around 50% of our cancer in their journey through the cancer treatment will probably come across our radiation oncologist and be advised about receiving radiation therapy, and that's the optimal utilization rate. it differs for different cancer. In cervical cancer, for instance, about 2/3 of our women would have received radiation therapy as part of that treatment, and a lot of our women would actually have a prolongation in life due to the fact that they have radiation therapy. Let's talk about cost. Cost is quite complicated and probably difficult thing to talk about, because there is the initial cost of set up the machine to procure the linear accelerator, for the planning and the ongoing operational cost. And cost is different in low-income country versus high-income country like Australia. So the upfront cost, say in the States or in Australia, might be about $800 or about 1,200 Australian dollars. But the ongoing operation and cost in US, $233 or in Australia about $330 for each treatment that patient receives. So may I just say that probably that not very expensive, and it is a very effective treatment. So why should we evaluate radiation therapy in clinical trial? You would have hopefully hear or advised by your GP, by your physician, that radiation had changed significantly, both technologically and our ability to deliver the dose where it need to do. Traditionally, when we want to treat the pelvis in the old days, we would have delivered what we call a box technique, bring in 25% of the dose from the front, the back, and either side, equal distribution, without much regard for the small bowel, for the bones. But modern radiation therapy is very different. We have the ability to select out what we want to treat and select out what we do not want to treat. So with modern technique like intensity modulated radiation therapy or volumetric arc treatment, we can select out not treating the small bowel, not treating the bladder, not treating the rectum, preserve the bone marrow for the time when you need to use it. And that's the beauty. But you can't just bring it out in practice. And I'm glad to share with you that there is a trial which has been published to say that the modern technique of radiation therapy has led to a reduction in side effects. And that's fantastic. Another new technique that patient might have heard is stereotactic body radiation therapy, whereby we deliver very high dose of precise radiation therapy in a small number of treatment, and that's very efficacious, say for lung cancer, that patient cannot go through with the surgery. In women with cancer, that's called internal treatment or brachytherapy, whereby we give very high dose inside the tumor itself. So those are the things that will be ongoing investigated. What we have achieved, I guess, in ANZGOG in terms of clinical trial, and you may have heard about the Outback already. And most of these trials that we conducted in ANZGOG always come from we asking the right question. And the question we asked for Take 3, because we noted that in our women with slightly advanced cancer of the uterus, there is a very high chance that with standard radiation alone, those women will actually have disease coming back outside the pelvis. So the question that the Take poses is, if we bring in the additional of chemotherapy on top of radiation therapy, would it make a difference? And I will share that with you. The same with Outback. Outback is a trial we try to address very similar question. We know that the combination of chemo and radiation therapy for intact cervix cancer work quite well. But we also know that maybe up to 1 in 3 women after those treatments still have cancer coming back. And that's mostly, again, outside the field of radiation. So is the additional of chemotherapy, would it make a difference? And we're still waiting the result for Outback. But for the Portec, I think what we know is in the Portec, patient who on what we call stage 3, more advanced cancer, when you add chemotherapy, those women tend to not see the cancer for a long period of time. And we hope that with long enough sort of follow-up, you will see that those very women will actually live longer as the effect of combination of chemo and radiation therapy. I came from Vietnam in the mid-1980, and there's a group that I like to listen to called the Divinals. And there's a line called, there's a fine line between pleasure and pain. And the pain of the treatment, or with any gain that we have, there is also that side of suffering. And that is, we see that in the side effects that our women going through with the trial experience. And you can see that patient having the combined treatment of chemo radiation therapy during the time of treatment experience more side effects. But the good news is by the time the long-term follow-up of 2 to 3 years, it's all equal. So I think that is a message that we need to give it out, is that yes, there will be a difficult time. I always tell my patient that the quality of life during treatment is not the same, but we hope to bring you back where you were before. And I think that's very important for us to do that. So we look at it, this is just another way to look at it, is in terms of global quality of life. We can see that during the time of treatment, it's actually not as good as when you have both chemo and radiation therapy. And the effect of the combined treatment on the low blood count, on diarrhea, fatigue, those tend to recover by 12 months. But what we noted in our study is the effect of numbness and tingling may last a little bit longer for a small number of our patients. In Australia, we never take on an international study and just do that for the sake of doing it. We always put in an Aussie slang. And what we do for Protect 3 is we do 2 different sub-studies. One is we call benchmarking. The beauty of benchmarking is that if you benchmark, i.e. if you have the same way of deliver the treatment through the concept of trial, then the kind of treatment that you deliver at the Centre of Excellence in Peter Mac is the same anywhere else in Australia. And we find in benchmarking, that's what we can achieve in Australia. So we conduct this and we find that after the benchmarking, the quality with which we deliver our treatment is highly uniform and of very good quality. In fact, even better compared to our international counterpart, because we have done the benchmarking exercise. The other sub-study that we do is, because center to everything that we do at ANZGOG or in our daily practice is you, our patient. And we ask the question, because these are the questions got to be asked. As we know, there is gain and there might be challenges. So we ask the question, among our patients who, about 83 of our patients who completed a trade-off questionnaire about whether or not they would be willing to go through chemotherapy and what would they willing to accept. And what we find is that over 50% of our patients judged that one extra year of life or an extra 5% survival rate would make the chemotherapy worthwhile. And we asked that among our physicians, and there's some similarity, is that the doctor would say, yeah, if you could make me live 1 year longer, I would take chemotherapy. But we push it a bit. We say that we might want to see a 10% survival rate. So when you compare, say, our patient with breast cancer, that is a little bit smaller. So our patient with breast cancer willing to take chemotherapy at a slightly smaller rate of gain. So I thought that was very interesting, and that very much Australian sub-study on the Protect 3. Where do I think the future of radiation therapy in terms of clinical trial? I think it's going to be two-way. One is that we will use what we have in our hands, the modern technology, in order to reduce side effects of radiation therapy, or when it's possible to actually take the radiation out of the equation to avoid side effects. And I will discuss that with you briefly. The second way that I think where we're going to go is use radiation therapy in combination with other systemic treatment like chemotherapy, immunotherapy, in order to prolong our patient life. So this is one of those studies. Again, we collaborate with our Dutch counterpart in a study. We hope to collaborate in a PORTEC 4A. And it is a randomized trial that in a group of women not as high risk as a PORTEC 3. So this is what we call intermediate high risk, whereby the standard treatment is vaginal vault brachytherapy, internal treatment. We argue that there is a subgroup of patients in that do not need the radiation therapy. And what we would like to do is through a panel of molecular profiling to identify exactly who those women are and say, look, you're very good. You do not need radiation therapy. And at the same time identify the very same women in that group that standardly would have been given vaginal vault brachytherapy and say, that might not be enough for you. We might need to give you a little bit more. And that is what we call molecular profile based. And we are still waiting for our grant to be assessed, but we really hope to be able to bring it in Australia, because I think that would be fantastic. The other thing that sometimes we like to look at is we know that despite all the effort, some of our women at some stage will come to a time when they have to face with the advanced, incurable aspect of the disease, with bleeding, with discharge, with pain, with obstruction. And there is a question of palliative treatment to try to improve the symptoms. And you could, as you can see on those pictures, I just used a picture of a cancer in the bone to illustrate 2 points. The first is that if you use the portal of front and back to give radiation therapy, like the one on the upper right versus the lower one, you achieve the same endpoint. But what the difference is that the one in the lower part is very precise, and it saves all of the bowel from going through with radiation therapy. So we want to ask that very simple question. If we use precise modern radiation therapy to palliate symptoms, and if we find that probably the way that we could get out of that is through patient report outcome. You will tell us what is the right way that we go about doing things. Let me share with you another 2 slides before I'm finishing. This is a report from the US looking at the characteristic of radiation therapy trials versus other cancer trials for a period of 10 years between 2007 to 2017. If you have 100 cancer trials, only about 5% are radiation therapy trials. And the industry is less likely to support radiation therapy trial, probably is not sexy enough. And I guess the other thing is the fact that radiation trial, because the technology is coming out too fast, and therefore the trials sometimes tend to not finishing in time, or not complete it in time. And that experience is actually similarly shared across the Atlantic. In Europe, they face exactly the same problem, but they're thinking of a few possible solutions. And the first is probably use the academic group to lobby the government funding and mentor the next generation, so that we have a succession plan of our younger generation will continue to do the trial. And we will continue to collaborate like the way we do in Outback, like the way we do in PORTEC 3, combined with chemo immunotherapy in order to make things better for our patient. And that would bring me to my conclusion, is that yes, I think we have made major contribution at ANZGOG in developing trials of radiation therapy sequencing with chemotherapy to improve cancer outcome and minimize toxicity. In the future, we hope to continue to ask the right question, and the right question have to have advice from you. To lobby our government for funding, to collaborate with our key stakeholders to facilitate the best high-quality evidence-based radiation therapy. I thank you for your time.
Does anyone have any questions for Dr. Doyle? With regards, yes?
We've just been chatting about CyberKnife. We've been chatting about CyberKnife.
Yeah.
What is that?
I think CyberKnife is probably one of the modern techniques that we use, in particular useful to treat CNS tumor, brain tumor. that work. Cyberknife, I guess, use the ability of radiation therapy and the robotic arm to actually bring the radiation to exactly where we want to do, using multiple gamma source. It is available at the moment, I believe, only in the private center in Sydney. It's not cheap. Similar to my discussion with you before, sometime in radiation therapy, we have not a good habit of bringing out new technology and have not, say, compare them with the best of our modern technology treatment. So using the normal linear accelerator in a public facility across the country, using the exact track to identify where the tumor is, with our modern treatment, we can similarly achieve probably the same result. But that has not been answered through a clinical trial. That's exactly why we need to have clinical trial. Sometimes we have the notion that if we pay money, 10,000, 20,000, we're going to have better treatment. That might not be true in the case of radiation therapy. Thank you very much for your time. Much appreciated.
I saw a little cheer happening out the back, Dr. Adams. That brings us to the next part of our presentation. And women with ovarian cancer being misdiagnosed, sometimes more than once, unfortunately is all too frequent. For women and their families, it is simply devastating. Without a reliable screening method and vague symptoms, there is no simple or quick solution to overcome these challenges. Survivors Teaching Students is an ANZGOG program and an international initiative where women educate medical students about their own cancer diagnosis, or commonly their misdiagnosis journey. Our next speaker is Dr. Helen Gooden, who has specialised in psychosocial support for patients in ovarian, pancreatic, brain and cancer of the unknown. She has a particular interest in health communications and consumer involvement in education and research. And that pretty much makes her perfect for her role as ANZGOG's Survivors Teaching Students National Coordinator. Please welcome to the stage Dr. Helen Gooden, and I'd also ask Kristen Young, one of our Survivors Teaching Students, to join her on stage. Thank you so much.
Thank you very much for the opportunity to come along and talk to you this afternoon. And I just want to welcome you from far and wide, because I know quite a lot of you have travelled from far and wide to come here today. And I'd like to also welcome our people that are watching virtually online. So we've had people today who've come from as far away as Western Australia, from country New South Wales, from in and around Sydney. Have we got any Victorians in the audience? We did have earlier. Yes, we do. So I want to thank you and welcome you today. So Survivors Teaching Students, this is a fantastic program, and I'm very proud to be the coordinator and launching this program around Australia. And I feel very privileged to work with all the amazing people that I do work with, women and caregivers, both male and female, that have been affected by ovarian cancer. And we have quite a number of those with us here today. As part of our annual scientific meeting, we've had a meeting with all of our coordinators from around Australia, and this has been their first opportunity to get together, and it's been a wonderful opportunity, and we've really enjoyed meeting each other and having that opportunity to talk and collaborate together. So Survivors Teaching Students, it's an innovative volunteer-led education and awareness program. It was started in the US by an organisation called Ovarian Cancer Research Alliance in 2002. And it was started by a woman whose name was Betty, and she herself had a difficult pathway to diagnosis. And she thought about this, and she thought, where can I make the biggest difference for the future? And she also believed in the power of one woman to make a difference. So she thought that working with medical students and our health professionals of the future, our future diagnosticians, was going to be a really powerful way to make a difference for the future. And as Professor Beale said earlier, in the absence of an early screening or early diagnosis test, this is the most powerful way that we can make a change for the future in ovarian cancer. So since 2002, the program has been taken up in the UK, in Canada, and just over 18 months ago in Australia, and we plan to be launching in New Zealand as well later in the year. There's over 1,200 volunteers worldwide working in this program, and we've reached more than 15,000 medical students, which let's just stop and pause and think about that for a moment. That's 15,000 of our doctors of the future who now know that when a woman comes in complaining of gynae symptoms, they need to be alert, to be curious, and to investigate and rule out ovarian cancer or other gynae cancers sooner rather than leaving that to be the last thing that may be looked at. If we can achieve an earlier and timely diagnosis, we can get women into treatment at the earliest possible time frame, the outcomes will be better. I'd also like to mention and acknowledge that this program has been able to start in Australia not only with the support of ANZGOG but with a Cancer Australia supporting people with cancer grant initiative. And with Cancer Australia support, that's allowed us to establish the program over the next 3 years, and we will be taking the program forward. So what are our learning goals? So it's all about the power of your story. We say to our students that this is a volunteer program, but every single one of our presenters have a PhD. They have a personal history of their disease and they're experts in their own experience. And your experience is extremely powerful to share with the students. The students have really responded extremely well to your stories, and they understand the importance now of listening to you. They understand the signs and symptoms of ovarian cancer that they need to be alert to. And the fact that we have 3 presenters talk in each of our presentation demonstrates to the students the diversity of the disease and how it can present in a number of different ways, and it is and across a number of different ages. And as you can see, a very important part of our message is the importance of communication in health and in a diagnosis of ovarian cancer, and how good communication with you and your family can make a real difference to your experience of ovarian cancer through your treatment. And you can see that our students really, from the feedback that we get from them, because we evaluate the students before and after your presentations. We evaluate them for a baseline understanding of ovarian cancer, and then afterwards we look again at their understanding of ovarian cancer and the shift in knowledge as a result of your presentations. And we also ask them some extra questions where they give us qualitative open feedback about the impact of hearing your stories and the lessons that they've learned that they want to take forward in their future practice. And as you can see here, it was valuable to hear from women and families directly about what we can do in our clinical practice to provide the best possible care to our future patients, no matter what specialty we are in. And that's a really important part of the program and why we deliver it to medical students, because it doesn't matter what specialty they end up going out and doing. It's quite likely or possible that they may come across a woman who has gynae symptoms, and having had an understanding from hearing your stories and the power of your stories, it actually sticks in their brains much more than reading it out of a textbook. And the other thing is that our students have been really impacted strongly and positively by the stories of caregivers, because caregivers are quite invisible in our health system. They're not in the textbooks, and giving our students, our medical professionals of the future, an understanding of how important the role of the caregiver is in your care, in your outcomes, and looking after you, and also looking after themselves. And it also helps them understand the ripple effect of a diagnosis of ovarian cancer or any cancer on the whole family. It's not just the person that's diagnosed. So what do? We share our stories. And this is Kristen, who we have with us today from Brisbane, sharing her story. You're in a unique position to help our students to become more sensitive to the signs and symptoms of ovarian cancer so that when they go into practice in the future, they have the opportunity and the understanding to potentially diagnose you sooner. And what do? You go into the classrooms of medical, nursing and allied health professional students in generally where you live, although at times we do a little bit of travelling, where you live, and you just share your stories. You do not have to have any sort of public speaking qualifications at all. The most important thing that you need to do to be able to do this program is actually just be yourself. Is just go in and be yourself and talk. Because as doctors of the future, they don't mandate who's going to walk in the door or how professional they're going to present to them or how together they're going to present to them. It's whoever comes. And that's exactly the qualifications that all you need to be part of this program is just to be yourself. So the forums that we present in, it can sometimes be a small tutorial group like this, and they're generally students in their 3rd or 4th year, or it can sometimes be 2nd year medical students or nursing students in a bigger forum. Our survivors and presenters who are here today, and Kristen will attest to you, that it actually doesn't make a lot of difference whether you're speaking to a large group or a small group, because our students are really respectful of you and they're very grateful for you coming and sharing your stories, and they're very respectful and interested, and they genuinely want to know what they can do in their future practice that will be the best thing that they can do. So how does it work? So I work with the Ovarian Cancer Research Alliance, which is the US organisation that started this program, and they've licensed it to us at ANZGOG free of charge, which means that we can use all of their training material so that we don't replicate costs. And I also work with our ANZGOG board, who are very large supporters of this program. And so what I do is I work with the universities and I establish an interest in with the universities, and if they see where they would like to include the program into their curriculum. And the program is of a 1-hour format, and it's designed to fit neatly into curriculums, but it doesn't have to. It can be presented as extracurricular or forums as well. But to date, all of our 11 university programs around Australia have integrated into their curriculum, and that shows how much they value the program. So once I've established that relationship with the university, I hand it over to our regional coordinator. So in each city where we're working, we have a regional coordinator. And here with me today, they can wave their hands if they would like. We have the Sydney Regional Coordinator, Brisbane Regional Coordinator, and the Townsville Regional Coordinator, where we're shortly going to be working with James Cook University. And we also had earlier with us our Western Australian coordinator, our coordinator from Victoria, and our coordinators from the Hunter and New England district. So the regional coordinator is the liaison point between me and the universities and their team. So the team on the ground consists of a facilitator, and the facilitator both runs the presentations at the universities and also looks after her team of presenters. And when we have a date allocated, the facilitator will get in touch with 3 of our presenters and see who is available to come along and speak on that day. We'll let you know all of the details, and we'll mentor and support you on that day as well. We always have 3 presenters in our presentations to give the understanding of the breadth of the disease, that ovarian cancer is not just one disease. It can affect different ages, different ranges and different stages. We also have the support of Ovarian Cancer Australia, who promote survivors teaching students through their wide network and reach for women to help us with our recruitment. We're always looking for new people who are interested in coming along, because our golden rule in being involved in the program is that life comes first, and we want to have enough volunteers in the program so that you have the opportunity to say yes or no to an upcoming presentation, and that you're free to go and do whatever you want to or need to do in your life without the program interfering, but you've got the opportunity to be involved. So in our first year, we have expanded the program and developed the program all around Australia. In fact, our 3-year project plan was to eventually get to 4 states in Australia in the first 3 years. But in the first year, we've in fact now we have programs running in all of our 3 initial target states, which are Queensland, Victoria, New South Wales and Western Australia. We have interest from the other states as well, and we are just limited by our capacity and funding streams to work in those states. But we have interest from Flinders University to work in Adelaide. We've got volunteers that have already signed up in Adelaide. We've got interest from the Australian Catholic universities to work around Australia, Notre Dame to work in Australia as well, and Griffith University on their in their campuses, which are both on the Gold Coast and in Brisbane. And we're shortly going to be looking at starting a program in Townsville with James Cook University. And in fact, we've got our first presentation with University of Queensland this Monday. And only last week, I trained 9 women in Brisbane who are really keen and excited to be able to be starting to present in the program. So these are some of our wonderful volunteers, and I've said that there's 60 plus volunteers because that number is never static. It changes every day, and in fact even changed today. So we had a constant flow of inquiries, and we contact each and every one of you, and it's in your own time when you're ready to participate in the program. There is absolutely no pressure on you at all. We look forward to working with each and every one of you should you be interested. The age range of our volunteers is from 25 through to late 70s, and we have both men and women caregivers working in our program. So this is Michelle in Melbourne doing her thing, presenting to Year 2 students. When Michelle came along, she said, "I'm not really a public speaker, I'm not really sure about this," and I reassured her that you actually just be yourself, go in and be yourself. And she actually found that she actually was a good public speaker, and she goes out there and she does her thing, you know. And the students really respond very well to Michelle just being herself, and that's what each and every one of you need to be. So as I said, it's designed to fit into the curriculum. We have a mixture of presenters, and very importantly, we always have 15 to 20 minutes of question time. And that's where the gold really happens. And the students are really interested, and they ask the questions that they don't often get the opportunity to ask in the clinical setting. You are, at no time are you expected to answer medical questions, because that's not why we're there. And also, if you feel uncomfortable answering any question, you can just simply say, "I feel uncomfortable answering that question." But to date, I don't think we've ever had a question knocked back. Facilitators? Nope, no, not to date. Yeah. As I said before, we evaluate the students before and afterwards, and we have also asked you to do evaluations with us too, because you are a very important 50% part of this program, and we need to know your feedback on how you're finding working in the program. And although there are program guidelines, there is tweaking that we do in response to your feedback to make our program as good as it can possibly be. From our evaluations of our first year, we've been able to see that our medical and nursing students are responding to the program, and that their increase in knowledge has been 23% across our medical cohort of students, and our nursing and allied health students have been from 32% in nursing through to 70% in the emergency medicine students. We pool our data with the international data set. So all of our data goes across to the US, and at the end of each year they do a comparative analysis with how we're tracking in Australia with the US, Canadian and UK programs to make sure that our message is on track and there's consistency across the messaging that we're delivering. In our first year, we've reached now more than 1,000 students, and that is well in over and above what we had expected. But it just demonstrates how interested the universities are in this program and how much they value it. Here are some of the students' responses, so it just gives you an idea of how well they respond and that they really understand the messaging. So just to read a few of them, that it takes it out of the theoretical and into the human, which is sort of the real reason we do medicine. And that's actually really important, because the students get really bogged down, and they're so bogged down in all of the learning that they've got to do that they can sometimes feel very separated and divorced from the people, which is the real reason that they set out to do medicine in the first place. So this is what is really the crux of this program. It's bringing the human element, it's bringing your stories and the faces and voices of your stories into the classroom, which is an extremely powerful way of learning. For you as survivors, as I said, we ask you to give us feedback on how you're finding the program, and some of the themes that have come through from your feedback to us is that it gives you a sense of regaining control of your life, a sense of purpose and validation, and that it gives you hope and feelings of empowerment in being part of the program. And a part of that, as Kristen will probably tell you, is the immediate feedback that you get from the students and how well they respond to your stories and you coming along and giving of your time and of yourself. We always ask you to allow at least half an hour after your presentations, both to debrief and talk to us, but also because mostly the students swarm out after you and they still want to talk to you and they want to thank you, and they're often known to hug because they're so grateful for your generosity in coming along and sharing of yourself and your story for their benefit and for the benefit of the women in the future. So the keys to the success that we have found is a good engagement with the universities across Australia, and we've certainly had that, and we've now got interest from New Zealand as well. And as I said, the benefits for our volunteers, and as one of our wonderful presenters said, speaking to medical students about our stories is an opportunity for us to give back for all the amazing support we have received over the past 3.5 years. And STS is one of the best things we do together. And that's because this particular presenter and her husband both present. And we're very grateful for the work that they do with us. They're also here. We have to talk about the hard facts of ovarian cancer to our students because it gives them an understanding of why we do this and why it's important to do this. But we don't dwell on them. And the important thing is, in you sharing your stories, is that we demonstrate that ovarian cancer is more than just facts and figures. And to demonstrate that, I'd like to introduce Kristen. Kristen is one of the original members of Survivors Teaching Students. She was one of the first people to put her hand up, and she's still a passionate advocate for ovarian cancer and for Survivors Teaching Students. She's a presenter in Sydney as well as a facilitator, and we're very thrilled that she's come along to share her story with you today. Thank you, Kristen.
So I'm Kristen Young. I'm a survivor of stage 3C ovarian cancer. So what I'm going to do is talk about STS from the volunteers' perspective. Obviously, Helen's described the program really, really well, including capturing the presenter's perspective really, really well. So I hope that does lead people to be attracted to joining it. And we're speaking also to those people out there in the virtual world who might be watching this as well. But what I might do is just do a slightly shortened version of the presentation that I do when I am presenting, so those of you who are watching can get a little taster of what an STS presentation looks like. We haven't got enough time for me to do it in full, but it's also a way of hearing my story as well. So I was diagnosed in 2009 at the age of 47. I was a busy professional person. I had no particular health problems other than those that come from just living too stressful a life. But what I first noticed was some large swollen lymph nodes in my groin. And I couldn't work out where that was coming from because I didn't appear to have any infections in my legs or anything like that. So I just really didn't do anything about that. But as the months went on, I began to get some more gynecological symptoms, some mid-cycle bleeding, which I didn't thought, well, maybe I'm 47, I can put that down to, menopause or something like that. But I did think I should ask my GP about it, and I have absolute trust in my GP, and I still do. And I said, could there be some connection between lymph nodes in my groin and me having unusual symptoms of gynecological nature? She said, no way could they be connected. And I thought, hang on, they're all in the same, geographical area, so surely, but no, that was her feeling. But as a good GP, she sent me off for a transvaginal ultrasound, which is one of the recommended actions that a GP should do when someone is complaining of these symptoms. And that came back with no evidence of any cancer or anything unusual except a few uterine fibroids, which is to be expected. But months went on, and I had another doctor I was seeing for an unrelated thing. They said, you shouldn't still be having 6 months later big lymph nodes like that, so I'll send you off for a biopsy. Went to see this general surgeon about that. He wasn't too worried. Had a look at my feet, couldn't find anything wrong with them. Don't know why you've got these lymph nodes. When would you like the surgery? And I said, I'm having a holiday in a couple of months and I don't want to, I want to be able to go swimming, so can I have it after that? He said, yeah, no worries, it's no big deal, sort of thing. So nobody was really thinking cancer at this point, so I didn't have a CA125. So I had my holiday and came back and did the little biopsy. And a few days later, I got a phone call at work. And you know how they say doctors shouldn't ring and tell you over the phone. Well, this is, of course, what he said. I know I shouldn't be telling you this over the phone, but I've got your results and there's a tumour. And he didn't say cancer, which was interesting. He said tumour. So I'm just saying, we all react differently to these words. But he didn't know what type it was. But he said, but I've already booked you in to see a surgeon and I've booked you in for a CT. So I knew it was obviously sort of quite serious. So I ended up going to see this surgeon and he was explaining, the standard procedure for the initial investigative surgery. And I remember piping up at one point and saying, don't you think I should be seeing an oncologist at some point? And of course, he was a gynecological oncologist. I'd never heard of such a thing. So he was a bit offended and said, well, I am an oncologist. It doesn't make sense to me. But the way he explained the cancer, he said, it's definitely cancer. It's probably gynecological and possibly ovarian. So I liked the fact that he was able to express that level of uncertainty to me. But then he said, all right, well, we can operate tomorrow or in my next list in 2 weeks' time. And my family, which was my mother and 2 siblings, saying, tomorrow. Because they think you got to act fast. But I wanted 2 weeks because I wanted to pack up my life, get out of my job, buy nighties, go on a pre-surgery road trip, all the things that you need to do. Oh, wrong way.
I think that there's the next slides. Yeah, Kristen's.
So sorry. I had, I had the very standard form of high-grade serous ovarian cancer, even though it did not present in a standard way. The lymph node presentation is not common, and I had no ascites at all, so I didn't have the bloating and the pressure that people get, which is a common symptom. So I am yet another example of a non-standard presentation, but of a very standard type. So I had the standard chemotherapy, the normal operation where they, take everything out, things I'd never even heard of, like an omentum. What's an omentum? And good operation outcome, everything cleared. Chemo went all right, horrible side effects. Even though I'm quite young and healthy, I still seem to attract side effects like, they just glue to me. So I had quite a lot of pain and stuff like that, and it affected my lifestyle. But I think one of my biggest frustrations during my initial treatment was being able to get the information I wanted from my doctors. I had every confidence in them clinically, but what I wanted is more access. I wanted more reassurance. But, I also knew, because I'm a health professional myself, that a doctor can't be there taking every little worried call from every patient on their books. There's a picture of my family here, and you notice there isn't a father in the picture because he not so generously gave me his BRCA mutation, and himself passed away from prostate cancer in 2003. And this is an interesting story in a way too, because his sister had she had died of cancer young with bilateral breast cancer, 58, and no one that was dealing with either of them, none of had sort of twigged to perhaps there was a family pattern here. And I think that's because back in those days they didn't have that emphasis on family histories and not much knowledge about BRCA. Had they though, our family would have been tested when Dad was sick. I would have found my BRCA mutation, then I would have been able to have had preventative surgery. However, that wasn't available to me, so I got ovarian cancer, and then that provided the opportunity for my family to all be tested, and then they were able to take whatever preventative measures were suitable to them. So being BRCA is good and bad. It's bad that you might get breast cancer, but I mean that's the least of my worries really. And I'm on a high-risk monitoring program for that, which my oncologist put me straight into. But the upside is there's treatment options, and people who've been listening today kept hearing trials for BRCA, trials for BRCA. That is the golden thing about having this. There is also the worry about whether you should have a preventative mastectomy, but I just can't face another operation. I first learned about ANZGOG at this time when I did my first clinical trial, and I wanted to be on a clinical trial not for the medication. I didn't much care about that. I wanted a clinical trial because I wanted the attention. I wanted someone to be looking after me. I wanted someone to listen to me and someone to talk to about my cancer experience. And I thought if I was on a clinical trial, they'd have to do that because I'd have to go in every 3 months or whatever it was. I still don't know after 2 years on that drug whether I was on placebo or not. But there you go. I lasted 4.5 years before my relapse. I thought I was going to get away with it, but I didn't. And the story gets really long from here, so that's why I'm going to wind it up. And I had a second surgery, second lot of chemo, and got into my happy space, which is a PARP inhibitor. I was desperate to get onto a PARP inhibitor. It wasn't available for first line when I was going through. It's coming on now, hopefully on the PBS sometime in the near future, I don't know. But this is the drug I wanted to be on. And 4.5 years later on this, I am still here defying statistics. The words unprecedented, uncharted waters, super responder, etc., apply here. So what do you do with a medicated life where you're not well, but you're not sick? So you try and do things that make yourself relevant. Try and make a life which is limited by the side effects of your drugs and the after effects of your cancer, but still is a high quality of life and a life of value. I get survivor guilt by my long remissions, but I've been told, and it does make sense to me, that I can be sort of a beacon of hope, even if other people can't necessarily get the remissions that I've been getting, that they can say at least somebody has benefited. At least somebody's getting something out of this research and these new drugs. So I'm quite happy to step up and be that person. So that's like what I do when I do an STS presentation, a little bit longer, a few more jokes, and I walk around a bit more. But I hope you can see that that's a fairly straightforward way of telling your story. It's a story, everybody knows their story really well. They present it in their own style. That's my style. In STS, you can present it in any style that's right for you. In fact, the greater variety of styles, the better. We don't want doctors to think that everybody is a public speaker with a flash story and a joke. We want some people to be sad. We want some people to read their story off a script. We want everybody to be themselves, 100%. So public speaking, interest and skills is a non-issue in being a presenter in STS. So this is me doing a webinar just to show that, I was pretty keen to get involved in something. Now, I've now retired from my job, but I was a psychologist. And one of the things that I did as a psychologist was I developed junior psychologists through the Army internship program. I wasn't in the Army, but that was my role, and I was awarded a significant award for a contribution to military psychology for that work. So I have a long-standing love of educating health professionals, and actually even predated my working with interns, and that's why I wanted to work with interns. So when I sort of heard there might be some sort of opportunity to work with educating medical students, Well, that's me. That's 100% me. I'm very comfortable talking medical terms. I like making a difference at a level that not just within our immediate support community, that makes a difference reaching out and also forward into the future. I'm also fascinated with communication and how communication works and fails, particularly within safety critical environments or complex environments. And I think, medicine is one of those incredibly complicated, high-risk environments, particularly when you're going into surgery. And communication, it's not just a matter of people learning to be nice and supportive. They've got to be able to make fast and constantly changing decisions about how to communicate. And I thought this is something that I can bring to the world by contributing to STS, because I'm very interested in that sort of thing. So we don't sit there thinking that when we list the signs and symptoms that those students 8 years later when they come back as an oncologist are going to remember that list, But what we believe and what I believe is that those students will remember the person. And I remember that I did my psychology training in 1981. We visited a mental hospital. Back then they had mental hospitals. And a patient sat in the room at the lecture theatre and spoke about his experience with a psychotic illness and the medications. And I've never forgotten him, 1981. And this is what we hope. And I don't think every person in the room will remember us, but I'm pretty happy if the hit rate is even 10%, but I reckon it's going to be a whole lot more than that. I reckon most of the people will remember us. How am I for time? Okay. So people remember people. They remember things through people. And medical students and nursing students too have got to do a lot of memorising and rote memory to learn. So if we're going to get them to take on board a message about ovarian cancer, you've got to sell it to them in a different way. And we know which way works best. It's through real people. So when you're watching them, and I've done them to groups of say 20 in a small sort of room and lecture theatres spreading right up like that. My goal is not that every face is turned to me with rapt attention, but I'll tell you at least half of them are, especially in the smaller groups. It's well more than half. And I think they just love to hear their area being given back to them in a really interesting way. And some of the stories we tell about the misdiagnosis and the clunky communication, I think people also like to hear those stories in a way, because we don't deliver those stories in a blaming or critical way. We're quite careful in STS not to slag the doctors, even though privately we might do that amongst ourselves if we're unhappy about something. But everybody likes to hear a bit of a story about things that went wrong. And as I said, we're not expecting them to get a bunch of facts, but I think what we would really like them to go away with is a sense of curiosity. And Helen said that word curious before, and that was going to be my big word for this afternoon. She took it from me, but that's okay. All I want is curiosity out of an up and coming health professional. And the other thing I'm looking for when I trained people, and I hope that the students get this too, is reflection. The ability to reflect on the things that they say when they communicate with us. They can't always get it right. A doctor is always going to be misunderstood by someone. They're always going to have a bad day where they say something a bit brusque or irritating that some patient isn't going to like. But what we want them to do is to be reflective and to think, that's how I come across. Or when I said that, the patient heard it as something completely different. And that's the thing I'd like them to remember, and I think STS does. An interesting thing is that there's a lot of people, as we know, the significant proportion of people in the community are touched by cancer in their own lives, and many of the students have had a cancer experience in their own lives, and some of they do come up and want to have a talk to you about that as well. That's just a thing to remember. And I also don't really think we're going to turn all the stage 3s and stage 4s into stage 1s, by looking at, awareness of symptoms. But it is still worth detecting a bit early. If nothing else, we could stop a stage 3 turning into a stage 4, or stop a stage 3, someone ending up with a colostomy bag and that sort of thing. So there's definitely worth it in that respect. Another benefit is there's a benefit to me. There's a benefit to the community, because an STS presenter, facilitator, whatever, belongs to a community of other people touched by ovarian cancer. And a lot of people don't want to be in support groups because they don't want to receive support. They don't feel they need it. But everybody needs social support. Everybody needs to belong and be in a community. So STS is a really interesting way to get a community based on your giving, but you also receive by being a member of the community. And it's darn good fun too. So that's really all I want to say. I think that for me, the future is very uncertain. I have no idea how long this remission will last and what happens when it doesn't go on. But at least by doing something like STS, I'm taking the skills and the interests I already have and doing something useful. And it's something that, even though all the research that they've been talking about in this conference, that's progressing along, this is something that we can do hand in hand with the research. We can make a difference by changing the minds of the future doctors, so their eyes are more open, they're more curious, more reflective of their own communication styles, and that may also have a benefit alongside actually the hard scientific research. So that's for me. Questions?
So we might get both of you up here to share this microphone and actually have some questions. Does anyone have any to start off?
Sorry, not used to this. Have you ever considered presenting to a small group of GPs?
Yes,
You know,
yes, we
maybe-
have, and at the Mercy Hospital in Melbourne, they have a GP education forum, and they've invited us to come along and speak to the GPs. The GPs are a very hard group to access because they're extremely busy, and it's very hard for them to take time out of their own practice because they're all like, as well as being doctors, they're in their own business. So that if they step out, there's no one else there to help them. So they're a very hard group to engage with. But through education forums and actually in Melbourne University, they've particularly asked us to present the program to the GP specialty stream. So that's doctors at the end of their training who have decided that they're going to go into general practice as their specialty, and that we're going to be working with them as well. And at ANZGOG, we're looking at other opportunities where we can engage with GPs and other doctors who are out in practice. But they're opportunities that come up, and when we have the capacity, we take advantage of them. But primarily our target group are medical, nursing and allied health students.
Does anybody want to say anything?
I spoke to Helen before. I think this is an amazing program, and I'd love to be involved in it. But I think it's just, as I said, if we can save thousands of lives while waiting for the research that's ticking away in the background to get funded, be successful, and then make a clinical difference. But I feel very passionately, and I'm very excited that this is happening, and I totally echo that previous question is hopefully this can get into the GP specialty program in all the universities, because that's usually our first line of help. Yeah. Thank you.
And thank you very much for your passion and for your involvement, and we look forward to having you on board. And we're only limited by our capacity, so the more of you that jump on board, the more opportunity we've got. So thank you very much.
So more of a statement than a question, sorry. So as you both know, I'm a doctor as well as a patient. And I know the benefit of this program. My favourite subject at university was genetics. It was because the presenter would bring in patients or patients' families. So, and I would remember, I still remember Huntington's disease, really rare disease, but I know Huntington's because they brought the patients in. And so I know that, but I also know from my own friends, because I've got a lot of medical colleagues, that by sharing your story with them and being open, like one of the guys, he's a ED trainee, so he will actually come in contact with women presenting to the ED with symptoms. And he said, Alicia, since hearing your story, it's changed my practice. So our stories, we can make a big difference, and the stories can be quite powerful.
I just want to also mention that one of our members, who's the head of the genomics laboratory at the Collins Institute in Sydney, after hearing about the program at our ASM last year, she asked me if she could send along her bench scientist to listen to the program as well, because they're working every day with your tissue, and she felt it was really important that she actually hear from you so that they can connect the dots. And so they came along to our presentation. They continue to look for opportunities to come along, and they were really powerfully impacted by your stories, and really grateful for that opportunity. Thank you.
So powerful, so very powerful. We're coming to a close of this session, but also of our ANZGOG's annual scientific conference. And I have to say that it's been for us an amazing time, and I would like to, I think it's very fitting that we invite ANZGOG's CEO, Alison Evans, to the stage to give us some final thoughts and to close proceedings. Thank you so much.
Hello everyone, it's great to see you all here. We've had 4 fabulous days here, learning an enormous amount about what we can do in the future as well as what we're doing now. I think one of the most, whenever I hear a Survivors Teaching Students presentation, kind of everything else kind of fades for me, so I've got to get myself back on track actually in terms of what I would like to say. But first of all, I think that this particular program, Survivors, is the beginning of what ANZGOG does with women in putting the message out there about what we need to be doing around gynecological cancers and ovarian cancer. And to us, even though we're a clinical trials organisation, it is very much an example of how ANZGOG tries to take a whole approach to what we do. And as an organisation, we feel that women telling their stories and talking to doctors in training and nurses is a critical part of us getting a message out there. Just as working with pure researchers in a laboratory who are coming up with an idea that is a preclinical idea is a critical part of us connecting the dots to our clinical researchers who are working in hospitals and other people who are actually testing these ideas with women. And then we believe that how we then pass that information back into the units and to women after we find out those answers is another critical part of what ANZGOG can do as an organisation to actually translate those results into treatments that people can have. So as an organisation, we've been operating in this space now for 20 years. The benefit that we've gained in that period of time is that even in the last 8 years, we've doubled our membership of doctors, researchers, surgeons and allied health professionals who use ANZGOG as a way of learning about the research that's happening in the space. And because of that growth of those people engaged in developing research, we've actually been able to develop some very significant initiatives which we hope will bring forward some of the answers, like our OASIS initiative and signal-seeking studies like Ali Freeman's, and others like that. So this day today, talking about all of those different types of activities by our different types of researchers is a critical part of spreading that word and having people understand what we're talking about. And the last 3 or 4 days that we've had with our annual scientific meeting has been a critical part of our doctors and specialists actually sharing that knowledge as a collegiate group and becoming excited about what they can be doing together. And I know from talking to some of my staff that we've been here working with those doctors that our pipeline of ideas for new clinical trials has been amazing out of this conference. And that's been quite outstanding. So it's wonderful to have you here at the tail end to hear about these other activities. As I said, ANZGOG's been in operation for 20 years, and we're celebrating some of our achievements next year, while we also plan what we need to be doing going forward from then on. And you've probably seen on some of these different screens that we have our old logo here with our gerbera, but we're actually moving to a much more contemporary look, which actually symbolises to us women. And in fact, I had a lovely story from one of our women on our consumer research panel yesterday, who said to me, I really love the woman symbol, and I love the way the cross at the bottom is not in the circle and the straight, which is what we're used to. She said to me, I feel like the woman is flying. And we felt that we'd done something right with that as well. So I want to thank you all for being here. I can assure you that from the conversations that I have with so many of our clinicians, that there is an absolute heart and commitment and passion to finding answers for the diseases that so many of the women we know suffer from. And we will continue to communicate with you as we go. Thank you.
And so concludes our session this afternoon. I hope that you've enjoyed it. Thank you for joining us both here in person and also live on our Facebook at Go for Gynae. Without anything else, it's a wrap, ladies and gentlemen. Thank you so much. Bye.